Hey guys, Joe here, and welcome to the last lecture series for Module 3 for RAD104. And we're going to be looking at how to protect people from radiation and some things to think about. If you want to look at some reading or open your book to get more information or to help clarify some of the information I'm going to be talking about, look for chapters 36, 39, and 40, and those should help you out. Okay? For this lecture, I'm going to start off by talking about protecting pregnant patients. And this is kind of a nice segue from our last lecture. The last lecture that we had, we ended off by talking about different exposure levels and how exposure affects or could affect the fetus in utero. And so what I'm going to start off with in this lecture is protecting the pregnant patient. So to summarize on what we talked about in the last lecture, when we were talking about periods of time within a pregnancy that are most susceptible or more dangerous for the fetus. We're going to start with the first 2 weeks after fertilization. Our big concern during that period is spontaneous abortion. Now, the chances of having a spontaneous abortion go up in just a minuscule amount to the point where it's almost negligible. People who never get an x-ray while they're pregnant will still have spontaneous abortion. There's still a rate of spontaneous abortion happening for whatever reason it may be. And just because you get an x-ray does not necessarily mean that your chances of having that spontaneous abortion go up dramatically. It goes up by 0.1%, but that's not dramatic, and that is not significant. So the chances of having a spontaneous abortion after an x-ray are relatively low. It's usually not a concern. It's an all or nothing effect. And so that almost never happens anyway. So that brings us to the next period of time, which is weeks 2 through 12, which is the period of major organogenesis. Now, it's during this time that we could have some type of congenital abnormality happen because the person or the fetus has been irradiated during the period of time when those organs are first developing. So again, could something happen? Something could. The chances do go up. They go up a small, minuscule amount, but they do go up. And then as we get further and further into the pregnancy, so we get into the second and third trimester, the chances of having any type of congenital abnormality after that is relatively low, very, very low. And on top of that, you have to think of the amount of radiation that has to be given in order for one of these effects to happen. We're looking at usually hundreds of milligray, which is a lot of radiation. Certainly nothing that we would see in a diagnostic radiology department. And so the chances of that happening are very, very, very low. Now, despite the extremely low chances of anything happening to a fetus in utero, there are still some other things that we could do to help lessen the chance of any type of exposure to a fetus in utero. Things like elective booking, having patient questionnaires about pregnancy, and having signs and posters throughout the department will also help in informing a patient that if they could possibly be pregnant, that they should let their technologist know. You should know that elective booking is the most direct way to ensure that a patient who might not know that they're pregnant is going to be giving their exam during a time period in which we know that they are not pregnant. So that you should know for your registry exam. However, in order to do that, one has to ask the patient about their menstrual cycle and when their next period is, and they'll try to perform the exam during that time period. Another effective way of doing this is just having a patient questionnaire that the patient would fill out before the exam is started, a piece of paper that the patient signs stating that they understand that there could be a risk if they're pregnant, and having this procedure or x-ray done just lets them know that if they are pregnant, that they should let their radiographer know that. And then signs and posters throughout the department can also inform them on the same thing, that if they think that they might be pregnant, that they should let their imaging professional know about that before the exam is started, and we would take any measures that we needed to in order to protect the fetus. That's it. Now, one last thing. Can a pregnant patient have an x-ray? Of course they can, and there are some circumstances in which absolutely they need to. The health and welfare of the mother may be in jeopardy, and so therefore we're going to be taking x-rays. And so when that happens, it really comes down to the radiologic technologist to do the right thing, select the correct technique, make sure that they collimate appropriately, And if you are shielding, that you're shielding appropriately, following proper protocol for the department that you're working in, and shielding appropriately. So those three things: technique, collimation's always so important, and then shielding if you need to. So all of those are important, and that is up to us. So yes, it is our job to ensure that we're keeping the mother and the baby safe during those types of procedures. And just to finish off the whole pregnancy and x-ray thing, here's an example of one of the signs that I've seen. It's in the book, but I've also seen it in a few hospitals that I've been at. So you may have seen a poster like this before. And it's just informing patients to know that if they're pregnant or think that they could be pregnant, that they might want to talk to their doctor about the exam or their rad tech before the exam starts. And that's pretty much it. So let's leave pregnancy behind, and let's think about protecting all patients with regards to x-ray and radiation. So one thing that we have little control over is reducing the those exams that we know are kind of bogus. We already know that some exams that are being ordered for some people are either just to protect the doctor, to cover their own butt, or maybe they just don't know enough about protocol. And sometimes that's where we can kind of come in and help out. A term that I want to mention to you is something called defensive medicine. And I've heard this term more and more as time goes by. And defensive medicine is really this. It's when a doctor or a practitioner orders more tests that are necessary just to cover themselves legally. And so there's an example that I've seen where this young person, let's say 20-year-old, goes into the doctor with chest pain. No history of heart disease, no family history, but because of defensive medicine, because they don't want to be sued, they decide to admit this person. They go through a stress test, they go through, EKG, maybe a cardiac cath, all of these different tests just to rule out the heart attack. When in reality, maybe it was stress, or maybe it was something atypical that was just going to pass. So there's a huge inconvenience for the patient. It ends up being an incredibly high cost for the insurance companies as well as the patient. But doctors are doing this just to cover themselves legally, because God forbid he sends that patient home and they do have a heart attack. Well, now they could be sued because they didn't do enough tests. And so what they're doing is ordering too many tests in order to cover themselves. Make sense? And sometimes maybe we can see this as rad techs. If you have someone who fell off a jungle gym and, their arm shows some deformity, and you've got the doctor that orders a hand, a wrist, a forearm, and an elbow, and a humerus. Do you really need to order all of those tests when really, we see deformity within the forearm, and you're going to get 2 views of the elbow in that forearm, and you're also going to get 2 views of the wrist with that forearm? What if we just did a forearm and then made a decision? Maybe we do see a fracture of the wrist, we will do a full wrist. Maybe we need more views of the elbow, but let's just start with the 2-view forearm just to see what everything looks like. So sometimes they need our expertise in helping them understand which views are going to be best and how can we save on the radiation dose of that patient by maybe being a little bit more smart on how we order those exams. Another thing that we need to think of is that there always has to be a reason for an exam. And so we no longer have unnecessary examinations, and that wasn't always the case. And so there always has to be a medical reason for that examination. All right, you can't just simply say, just follow up. Follow up to what? Was it a follow-up because they've had pneumonia, follow-up on a cough, shortness of breath? What is the reason for follow-up? So you can't just use vague terms. You can't have no reason at all. There must be a reason, a medical reason, for doing a specific x-ray. Now this slide just shows some of the examples of when, and this wasn't too long ago, but there were times when we were performing x-rays just because. So, and the one I think of is pre-employment physicals, okay? So you might not have any symptoms, but in order for you to finish your pre-employment screening, you would have to have a chest x-ray. That's no longer the case, especially if you have no symptoms. So you can't do that anymore. It wasn't long ago, and I remember when this was happening when I was a student, so about 10 years ago, before you were admitted, okay, we knew you were going to be admitted, you got a chest x-ray. You might have been there for a broken leg. It doesn't matter. You're getting a chest x-ray because we didn't want you to have any type of breathing problems while you were admitted. And in order to understand whether or not you could have a breathing problem, we were going to do a chest x-ray. that is no longer a good enough reason to do an x-ray. So there's no more required chest x-rays for hospital admission. Periodic health examinations, and from time to time, I remember maybe 5 or 6 years ago, every once in a while I get a person who comes in and says, yeah, I'm getting a chest x-ray, I don't have any symptoms, but I just haven't had a chest x-ray done in maybe like 3 or 4 years. Well, that too, there's no reason. You're not having any signs or symptoms, you should not be getting an x-ray. I think you might still see those from time to time. Overuse of emergency room CT, that kind of goes with that defensive medicine aspect that I talked about earlier. Whole body multi-slice helical CT scannings. There used to be a time when you could go to a mall or a private company and they would scan you from head to toe. So it's basically a whole body dose, and they would find everything wrong with you, whether it be a benign tumor or enlargement of the kidney or whatever. They would find all of these things just to let you know. So, but again, not good enough. You can't do that anymore. And so this is going to kind of go along with something I'm going to talk about later in one of these lectures, is about how you have overuse of medical imaging, and overuse because of defensive medicine, but also because you also have the public who read up about these different types of exams and they want to have one. So you also have pressure from the patients themselves to get these exams done. All right, I know I'm going over my time, so I'm going to finish up with a couple slides. We'll end this one here. So, repeat examinations. That is where we come in as technologists, okay? We have the ability to be careful enough to avoid repeat images. And a lot of times it's under our control. It's not necessarily that the machine malfunctioned or something didn't work. That's usually not the case. It's usually because of technologist error. And it's usually because of things that we do that we might have to repeat an image, whether it be positioning or because we didn't have the right panel activated for that exam. Could be a lot of different things, but it's usually technologist related. Now, we have been keeping track of your repeat rates. That's why it is so important for you guys to make sure you talk about all of your repeats in your daily logs. It's not to get you in trouble, but to help you improve, because some of you are 10% or higher on your repeat rates. Now, you're students, and it's okay. Again, you'll never get in trouble for repeat rates, but we do point them out to you to say, we do notice that you seem to clip anatomy quite often. This is something that I just want you to focus on. All right. And so it's very important that we follow that and you track that correctly and accurately so that we can give you good information. Hospitals, I don't know if they necessarily track these repeat rates as thoroughly as we do as a school is concerned. But repeat rates, they say in the book, shouldn't be any higher than 5%. I don't know if I believe that. That seems pretty low. I think even seasoned technologists are going to be over 5%. So I could be wrong on that, but repeat rates are very important. And you should know that examinations with the highest repeat rates are lumbar spine, thoracic spine, and abdomen. Good to know. All right, last slide for now. Again, just talking about how repeats are mostly because of technologist error, not because of equipment malfunction. Most repeats are because of improper positioning. Sometimes that is technologist error. Sometimes it's the condition of the patient that deal with positioning, but still, it's up to us to get the proper position for the doctor and for the image. Luckily, radiography that we use today, the digital system, uses very low amounts of radiation, and it allows us to check or manipulate the digital data to make a better image where we don't have to repeat it. That would be great. And again, different repeat reasons include motion, artifacts, grid errors, wrong projection, improper patient positioning, improper patient preparation, bad collimation. Those are all examples of repeat reasons and things. A lot of them are things that we could help avoid. So just remember that. And with that, I'm going to end this video. If you have any questions, shoot me an email, ask for a Zoom meeting or a face-to-face or whatever. We'll figure it out. But sorry it's so long. I'll see you at the next video.